Welcome everyone, my name is Eliza Tóth and I work for Pannon Business Network Association in Hungary, and we are participating in the RehAllianCE project, and today in this short presentation I will introduce the RehAllianCE best practice collection, why it was created, what it contains and what we can learn from the collected examples. The focus is not only on the technologies themselves but also on how they are implemented, validated, financed and transferred into real healthcare and care environments. So let me start with this collection. Why is it relevant for the rehabilitation sector? So the RehAllianCE project aims to improve rehabilitation services by identifying, evaluating and sharing best practices in rehabilitation technology. The collection responds to a very practical challenge. Many innovative solutions exist, but they often remain fragmented, local, or difficult to scale. The collection therefore supports knowledge exchange among healthcare providers, researchers, policymakers, and technology developers, and it also helps identify what makes a rehabilitation solution effective, scalable, and adaptable to different regional or national systems. To understand the logic of the collection, we first need to clarify what RehAllianCE means by a best practice. In RehAllianCE, a best practice can be a product, a service, a program, a policy instrument, a funding model, an organization, or another type of solution. The key criterion is that it has already demonstrated value in a real context and may offer lessons for other regions. The practices were analyzed through three main categories. The first is technology, including institutions, testing methods, and reports. The second is finance, including financing models, reimbursements, public programs, and commercialization. And the third is test and development, including R&D, cooperation, verification, treatment effects, and cost-effectiveness measurement. Based on this framework, partners collected best practices from several European regions. Just to provide you a glance of the collection, it includes a broad range of practices from the participating countries and regions. They are very diverse. Some are clinical service models, some are digital or robotic technologies, some are policy or financing instruments, and others are research, testing, or innovation environments. The diversity is important because rehabilitation innovation is not only about introducing new devices, it also requires service redesign, staff training, patient involvement, financing models, monitoring, and long-term sustainability. To present the collection in a clear way, I group the practices into four thematic areas. But before that, just looking at the practices collected, you can see here the practices from Poland and Hungary. On the next slide, we can see the practices from Germany and Austria. And on the last slide, we can see the practices from Italy. So to present this collection in a clear way, I group the practices into five thematic areas. The first one is about bringing care closer to patients. This first group shows how rehabilitation and care can move closer to the patient, into the home, the community, an outpatient setting, or a hybrid care model. Here you can see the relevant best practices. HPRC from Poland is a good example of integrated chronic wound care. It combines prehabilitation, patient education, psychological support, and remote monitoring through the eCareMed platform. From Hungary, at.home provides a smart senior room where seniors, caregivers, and companies can test digital solutions for independent living, while Careful Watch offers a national 24/7 emergency support service for people over 65 living at home. Austria brings two relevant examples: the ambulant geriatric immobilization, which provides outpatient support for elderly multimorbid patients, and Reha 2030, which focuses on telerehabilitation after stroke. The key message here is that best practices can reduce dependence on hospital-based care when services are redesigned around the patient's home, community, and everyday environment. The next theme looks at how technology can increase therapy intensity and efficiency. So the second group focuses on robotics, mechatronics, and technology-supported neurorehabilitation. A common challenge is that neurological rehabilitation often requires intensive, repetitive, and task-oriented therapy, but health systems face staff shortages, reimbursement limitations, and increasing demand. The Polish Luna EMG multi-unit concept is a strong efficiency example. 4 robotic devices can be operated by one therapist, allowing several patients to train at the same time. Modern neurorehabilitation combines robots, virtual reality, training platforms, and patient assessment tools to provide more personalized therapy for neurological patients. Germany's IMS-IMR focuses on mechatronic systems, prostheses, orthoses, and exoskeletons, while the Polish robotic device financing program shows that scaling robotics also requires targeted public funding. The key message here would be that robotic and interactive technologies can increase therapy intensity and efficiency, but they need financing, trained staff, and workflow integration to scale. Beyond robotics, many practices also shows the growing importance of data and monitoring. So our next theme is showing that the increasing role of data in rehabilitation and care. The focus is not simply on collecting data, but on making it meaningful for clinical decisions, monitoring, and service organization. The German heart failure set is an example of telemonitoring integrated into reimbursed care. It allows patient data to be monitored remotely and supports earlier intervention when values changes. Mobilize D focuses on validated data mobility outcomes. It uses wearable sensors and real-world walking data to better understand mobility loss and related clinical risks. IntegraSkin applies AI and personalized medicine to support treatment decisions in chronic inflammatory skin conditions. The Italian smart rehab environment uses smart rooms and cloud-based monitoring so that physiotherapists can supervise patient activity more efficiently and safely. So data-driven rehabilitation supports earlier intervention, personalized decision, and safer care when monitoring tools are clinically validated and integrated into services. However, successful innovation also depends on user acceptance, motivation, and everyday usability. The fourth group is about this, the acceptance, well-being, and engagement. These practices show that rehabilitation-related innovation is not only about clinical technologies, but also about motivation, confidence, participation, and everyday usability. The Hungarian Silver Club involves seniors directly in testing digital solutions and giving feedback to developers. This helps create technologies that better match real user needs. Austria's Smart Vitality tested assisted living technologies in real households, giving valuable evidence on acceptance and everyday use. Italy contributes two well-being focused examples, virtual reality relaxation scenarios, which using immersive environments to reduce anxiety, and Self-Help Plus, a digital stress management assistant for vulnerable women. Germany's Apelvo shows how gamification and support can support pelvic floor training and make exercises easier to integrate into everyday life. The key message here is that digital tools become more effective when users are actively involved, motivated, and supported in adopting them in daily life. The last thematic group looks at the system conditions that allow such practices to scale. So the final thematic group looks at the system conditions that make innovation possible. The previous themes focused on services, technologies, monitoring, and user engagement, but even the best technology will not spread if there is no funding, no reimbursement, no implementation capacity, or no cooperation between regions and institutions. The Italian Transforming Health and Care System Partnership is a strong example. It supports coordinated research and innovation funding, capacity building, knowledge exchange, and scale up across countries and regions. The Polish robotic device financing program shows how public funding can help healthcare providers acquire advanced rehabilitation technologies. And the German heart failure set also fits here because it shows how telemonitoring becomes more sustainable when it is integrated into reimbursement and routine care. The key message is best practices can scale when financing, policy, evidence, and implementation capacity are aligned. After these thematic groups, we can summarize what makes selected best practices measurable, transferable, and sustainable. This slide brings together the key messages of the whole collection. Best practices are not transferable simply because they are innovative. They become transferable when there is evidence, when the implementation model is clear, and when other regions can understand what resources, partnerships, financing, or organizational changes are needed. From Poland, I would highlight HPRC, which shows that redesigning the care pathways can improve both care quality and service capacity. The average hospital stay was reduced from 14 to 10 days, and more than 1,510 patients were discharged in 2023 with the same 66 beds. From Hungary, Careful Watch shows national scalability. Almost 90,000 devices were deployed in the first 3 months, and the service reached 2,890 municipalities. Its sustainability comes from public funding, free access for users, and 24/7 dispatcher infrastructure. From Germany, Mobilize D shows transferability through validation and standardization. It brought together more than 300 partners from 34 organizations and developed validated digital mobility outcomes supported by shared data, algorithms, and research resources. From Austria, I would highlight ambulant geriatric mobilization, which shows a sustainable outpatient model for elderly, multimorbid patients. It is reported as 56% less costly than inpatient care and became a permanent regional service after the pilot. From Italy, Smart Rehab Environment shows how smart room technology can increase capacity by maintaining safety. It achieved a 30% productivity increase, monitored all patient activity time, and registered no adverse events during the pilot. These 5 examples show that the collection is not simply a catalog of technologies. It is a practical knowledge base for understanding what works, under what condition, and how regions can learn from each other when designing future rehabilitation pilots, policies, and investment priorities. To conclude, the RehAllianCE Best Practices collection gives us a structured overview of what is already working in different European contexts. It shows that successful rehabilitation innovation requires more than technology. It needs user involvement, evidence, financing, staff capacity, organizational change, and policy alignment. At the same time, the collection is not an end product on its own. It will be used in the further stages of the RehAllianCE project as a practical knowledge base. The examples will feed into comparative analysis, help identify common challenges and success factors, and support the development of strategy and policy recommendations. The good practices will also be important for pilot planning and design. They can help us understand what types of solutions are already working, what conditions are needed for implementation, what risks should be considered, and which elements could be adapted to other regional contexts. My final message is that these practices are not isolated success stories. They are building blocks for knowledge transfer, evidence-based planning, and the next implementation-oriented steps of the RehAllianCE projects. And this is the end of my presentation. Thank you for your attention.